Well, thank you very much for the opportunity to present here at this very exciting meeting. In this talk, we'll go beyond IVUS and OCT, and that means we'll touch on computed tomography. We'll touch on near-infrared spectroscopy and its use combined with IVUS and OCT, and we'll look at some other investigational imaging techniques, however, only briefly, because I think that will also be featured in the next talk. And interspersed are a couple of specific use cases for these imaging modalities in DCB PCI. As we've already heard, angiography provides a two-dimensional luminogram that is very useful, but it does have some inherent limitations because of its providing information only regarding the lumen and not on the lesion composition, and also inherent limitations in providing a two-dimensional view of a three-dimensional object. And even though at every meeting you always hear about OCT and IVUS, its uptake still remains limited, and it can be challenging to acquire and interpret. Not everybody is an amazing intracoronary imaging expert, and both IVUS and OCT have some limited efficacy in detecting vulnerable plaques without adequate training. Of course, coronary computed tomography angiography has undergone tremendous progress in the last couple of years, and it provides anatomical information, but it also provides information regarding coronary physiology. Thanks to artificial intelligence combined with computational fluid dynamics, we can accurately represent the physiology of not just a lesion or a segment of a single vessel, but the entire coronary artery tree. And it also provides information regarding plaque composition. And again, there's an important role for artificial intelligence here, because with this software, it's possible to quickly, without a lot of human interaction, get the entire plaque composition, again, of the entire coronary artery tree. And it's also now recommended as the first-line imaging modality in patients presenting with chest pain by US and European guidelines. For CT, a development that is extremely promising, of course, is photon counting, because the limitation of the CT is that it is very specific, very sensitive, so it's very good to rule out coronary artery disease. But once you have coronary artery disease, it tends to overestimate its severity, and that can cause to a lot of false positives that end up in our CAD lab, and then we see these patients, and we've done a CAD. We could also maybe have not done a CAD and save the patient the invasive procedure. Now, traditional energy integrating detectors consist of a scintillator, which converts X-ray photons into visible photons that then get converted to an electrical signal in a photodetector. But the photon counting detectors can directly convert individual X-ray photons into electrical signals, leading to higher resolution, lower noise, and they can handle stents and calcium much better, so there will be no blooming artifacts. But even with DCB, I think there's an important role just with these traditional detectors, which are going to be around for much longer. They're much cheaper. They're much easier to build. Because we don't leave anything behind, it's very promising to also use traditional CT as a screening and follow-up tool after DCB PCI. With current software, with current CTs, we can already do amazing things. We can visualize arteries much better, get these three-dimensional ideas. Here you can see that there's a beautiful LAD bifurcation lesion where the calcification is highlighted, where we can see the angulation, but also the myocardial mass of the side branch and the main branch. We get an idea about the physiology and also about different stent strategies. If we put a stent here, just in the main vessel, and what if we do a more complex strategy, and what is the benefit of doing that? Of course, the limitation is that we know this for drug-eluting stents, but this is not known for drug-coated balloons. And also with the late lumen enlargement effect seen in some DCBs, this may be completely different for type A DCB versus type B DCB, and it may be different 1 week after the procedure compared with 9 months after the procedure. So again, important knowledge gaps. Of course, having a better idea about the plaque composition before we even go into the procedure is very important. An AI evaluation of the CT can therefore impact treatment by having this idea of the entire plaque morphology. And there's already multiple FDA-approved vendors that offer these types of technologies. We can go on for multiple days about CT-guided PCI, but I think some other important promising applications are the visualization of CTOs, the use of optimal X-ray angulations as well to improve our visualization, minimize foreshortening and minimize overlap, knowing when we're dealing with anomalous takeoffs, so we can go in better prepared, use less dye, go with the right guiding catheter, and of course, much better visualization of calcifications. we don't have enough time to cover everything about CT, and we don't have enough time to cover everything about NIRS, but it's important to know that near-infrared spectroscopy is interesting technology that helps to detect lipid, and this can be combined with both IVUS, as in the dual pro system by InfraredX, or with OCT, as in the hyperview system by SpectraWave. And here you see an example of the added value of NIRS. So there's a 2D IVUS image acquired by the dual pro, but then on the other side there's the chemogram that NIRS gives you. On the x-axis it's the pullback longitudinally, and on the y-axis it's the transverse of the vessel, and then you can clearly appreciate the presence of a lot of lipid. So you don't have to be an imaging expert. There's a lot of stuff going on in those 2D images, but the chemogram is very clear. It's just about the lipid, and you know where it is. These vulnerable plaques have important implications. They are known to be present in approximately 50% of ACS patients in non-corporate lesions. We know this from the LRP and the Prospect 2 studies. And those are mostly non-flow limiting lesions that are associated with an increased risk for MACE. And we also know from the PREVENT trial that treating these vulnerable plaques, on top of medical therapy, of course, antiplatelet agents, anti-lipids, anti-inflammatory agents, can lead to clinical benefit. This should ideally be a one-time treatment that achieves plaque stabilization, and the benefits should outweigh the risks. And invasive options include drug-eluting stents, but they leave behind a permanent implant with risk of restenosis and stent thrombosis, or the BVS. But again, there's risk of restenosis, scaffold thrombosis, and unpredictable resorption of the scaffold material. And indeed, in PREVENT, there was a significant interaction between the DES and the BVS, where the benefit was limited to the use of drug-eluting stents, and it was not seen with bioabsorbable vascular scaffolds. So maybe drug-coated balloons are actually the ideal treatment for these vulnerable plaques, as they allow local delivery of drug with minimal injury to the vessel without a permanent implant, and they can theoretically be coated with different types of drugs. There is, however, some preclinical evidence, both for paclitaxel and for sirolimus, that suggests that they may both be very interesting candidates for this application. And they can therefore be a very attractive option for high-risk patients, for example, those already undergoing an invasive strategy for an ACS. This is an example of a patient that we did as part of our pilot study in Amsterdam, a 69-year-old male with a non-STEMI. This is his diagnostic coronary angio. There's a culprit lesion in the obtuse marginal that was treated with a drug-eluting stent. We then performed 3-vessel IVUS NIRS as part of the study protocol, and then we identified a lipid-rich plaque more proximal in the circ, which you can, angiographically you cannot really appreciate it, but it's clearly there on the IVUS NIRS. This is the two-dimensional IVUS. So there we see that the plaque burden is not that high, it's 67%, MLA is 4.3. In this case, as part of the study, we treated it with a Sequent Please Neo paclitaxel-coated balloon, and then immediately after we repeated the IVUS NIRS, and there's only a minimal change in the max LCBI, went from 425 to 382. We brought the patient back after 9 months with angiographically good results, no differences compared to the result at the initial procedure, but now at 9 months, the LRP has almost completely resolved. This is published, this experience of the first 20 patients is published in Eurointervention last year, and we are currently investigating this in a randomized control trial called the LEAD LRP. So we are comparing the treatment of these non-corporate vulnerable plaques in ACS patients with Sequent Please versus guideline-derived medical therapy alone. And in this study, we have also integrated the use of CCTA. Patients get a CCTA after the initial procedure, and they get it within 2 weeks before their follow-up procedure, when again, angio and IVUS NIRS is performed, and the primary endpoint is assessed, which is the difference in the max LCBI 4 millimeters of the target LRP between baseline and 9-month follow-up. And for this study, we've also collaborated with Clearly, who will be using their AI QCT software to also look at the CT characteristics of the plaques immediately after the procedure and at the CCTA at follow-up. Now, there's some other interesting intercoronary imaging modalities that are currently undergoing preclinical and sometimes even clinical testing. There's a very good recent review paper by Tufaro in JACC Interventions that I can definitely recommend to read if you're interested in this, and I think we'll also hear more about this in the next session. And all of these intercoronary imaging modalities have some specific strengths and weaknesses, and some of them are really good at visualizing neovascularization, macrophages, the cap thickness, cholesterol crystals, or even endothelial apoptosis. And there's obviously a lot of interesting research still going on in this area. I personally believe that we will be moving towards an era of multimodality imaging of vulnerable plaque. I think the CCTA will be playing a ever larger role in our daily clinical practice. First in elective PCI, later I also believe so in ACS PCI. The CCTA can already tell us about the type of plaque that we're dealing with, and we can then confirm that with IVUS. I think the intracoronary imaging will always be an integral part of the procedure because the CCTA only gives you an idea about the initial situation, but obviously you want to know what happens after you've been working in the coronary artery as well. And this can also be a way to confirm the potential presence of vulnerable plaque and maybe do a treatment of the vulnerable plaque if that's shown to be effective in clinical research. So to conclude, artificial intelligence will allow the application of CCTA to improve the safety, efficiency, and long-term outcomes after PCI. And CCTA may also be a very interesting way to follow up our patients who have had DCB, and maybe also even those patients who have dissections, particularly when the resolution of the CT is high enough, as with the photon counting CTs that we'll be seeing more and more in our clinical practice. Artificial intelligence will also allow the adequate identification of vulnerable plaques in vulnerable patients. There are already many algorithms out there, which mean that you don't have to be Akiko Mihara, but you can just be yourself, and you can also still see all these details in the entire pullback of the intracoronary imaging that you're doing. And ultimately, we're investigating whether these drug-coated balloons may be ideally suited for the local treatment of vulnerable plaques. Thank you very much.